Hello there and welcome back. This is a lecture on common periodontal lesions. So lesions that a dentist is going to pretty much every day see around the dentition. So starting with periapical inflammatory lesions, periapical cysts, then we'll get to dense bone islands, idiopathic osteosclerosis, cemento-osseous dysplasia. You won't see every day, but these are more common than other type of lesions that we'll get to later in the course. Hypercementosis, cementoblastoma, and root resorption. So starting with periapical inflammatory lesions, just a quick review on acute versus chronic inflammation. Hopefully you remember acute is associated with rapid onset, fever, very pronounced pain. So if someone describes something as sharp or shooting pain, and this is associated with bone resorption as opposed to chronic, which is associated with bone formation. That's more associated with gradual swelling, intermittent low-grade fever if there's a fever at all, and less intense pain, more of a slow onset. So think of the osseous response to inflammation as either laying down more bone or resorbing bone. Now know that the bone metabolism normally involves a balance between these two. Osteoclasts are always resorbing more bone and osteoblasts are laying down more. That's normal in healthy bone formation. And so it involves a balance of these two things. And an inflammatory response will create an imbalance. So either osteoclasts take over in the acute inflammation and you start resorbing more bone, or osteoblasts have a more profound effect and you lay down more bone, and that's when it becomes sclerotic, as if the inflammation is stimulating a response to try to wall off the injury. So radiographic features of inflammation. This is really helpful, right? It can be ill-defined or well-defined. It does kind of vary. We'll show you examples of where it is ill-defined. And in fact, this image right here shows parts that look very well defined, and then down here it looks ill-defined. This one looks a little more ill-defined, kind of a blending border. And so blending, that's just think of it as a synonym for ill-defined. When the border is not very clearly distinguished, you can't draw a very sharp line around it. And this is the mechanism you should be familiar with. Caries or whatever type of injurious stimulus, it can be trauma, so a fracture, anything that exposes the pulp space, or caries that invades into the pulp, into the nerve. When it's severe enough, it can cause a necrotic pulp. That's when the nerve dies inside the tooth, as you know. And that can lead to a periapical inflammatory response. If this goes unchecked, and if the inflammatory response is severe enough, it can eventually lead to osteomyelitis. For today, we're going to focus on just the focal form of this disease, inflammatory lesions that stay focused right at the apices or around the teeth. So abscess versus granuloma, we'll talk about those. When do you suspect it may actually be a periapical cyst, and it's kind of taken on a life of its own, and now it's an actual cyst, and even after removal of the tooth or after root canal therapy, the cyst will persist, and it can continue to grow. Versus condensing osteitis, and these are just kind of definitions that you need to know. Later on in the course, we'll talk about these more diffuse forms, osteomyelitis, and other things related to osteomyelitis that have different causes. So apical periodontitis, if you've had your endodontics course, you've probably heard this term by now. Acute versus chronic, I just talked about the difference between those types of inflammation. But apical periodontitis is just a term for when the nerve has become necrotic, the nerve has died, and the inflammatory stimulus starts resorbing or laying down more bone around the apex of the tooth. And so these words you can use pretty much interchangeable: periapical, radicular, periradicular. An abscess is defined as more an acute inflammation. So when you have acute inflammatory cells, that's associated with purulence, associated with all those symptoms that we talked about with acute, where it's very fast onset, can be associated with fever. This is a patient that comes in very severe pain. It may have arisen in a matter of days or hours, and they're just in a lot of pain. They may have a lot of swelling, even some heat localized to wherever that swelling is from their teeth. Granuloma more implies that it's chronically inflamed tissue, and so they may have more low-grade pain. They might have a low-grade fever, but acute, the abscess is more often associated with a fever. And then a cyst, this is where you actually develop kind of a new type of pathology. So the stimulation from the inflammatory cells stimulate some of the epithelial cells to turn it into an actual cyst. And what is a cyst? It's a fluid-filled sac of epithelium. And so this is developed into a different type of pathology. I'll still categorize this as an inflammatory disease because it came from inflammation from a tooth. It came from a necrotic tooth. But now it's taken on a life of its own, and it can continue. And so a little thought question for you. Hopefully you should be able to answer this. Periapical abscess coincides with what? Chronic or acute inflammation? Abscess, we said that was acute. Granuloma, on the other hand, is associated with chronic inflammation. And a periapical cyst is a sac of fluid with a what type of lining? What's the definition of a cyst? Epithelial. All right, just some more terminology. I think of rarefying osteitis as a fancy radiographic term that radiologists use. Rarefying meaning it's kind of losing its density. So the bone loses its density. Think of that as the radiolucency. So when you see the radiolucent component to a periapical lesion, you could call it rarefying osteitis. So if you hear that term, be able to identify it. Or it can be a granuloma or abscess. But typically it's when it's talking about the radiolucent component. Condensing osteitis, on the other hand, is just the opposite. It's where you're focused more on the opaque part. And some lesions, for whatever reason, is just the human's response, the person's response to that particular inflammation. It becomes more chronic, and the bone reacts by laying down more bone. So the osteoblasts are more active, and it lays down more bone around it, and for whatever reason, it turns to more of a dense reaction. We call that reactive bone or sclerotic bone, a sclerotic border around it. So increased opacity. When it's very largely opaque, you'll call it condensing osteitis. Now, I've never seen a lesion that is solely opaque if it's a periapical inflammatory lesion. I always see, and we'll see examples of this, I always see some degree of radiolucency at the apex. We know there are lateral canals. A periapical inflammatory lesion can come from the lateral surface of a root, but I never see condensing osteitis without some degree of PDL space widening or some type of radiolucency, typically at the apex. This just shows an example where you can have an inflammatory lesion, you can have symptoms, you can have periapical periodontitis, and not even see any radiographic changes. So, assuming they did the vitality test, obviously we see this big missing portion of the tooth, likely invasion of the pulp space. They did the vitality test, it's non-vital. Did a percussion test, the patient is really sensitive, so they're diagnosing periapical periodontitis, but that is a clinical diagnosis because radiographically, you don't see anything around the PDL space of that tooth. It looks uniform, it looks normal. I mean, maybe you could argue there's a little bit of widening, but that's within the range of normal variation. If you look at the molar, you do see a periapical lesion there. You see the radiolucent component, you see a little bit of sclerosis around it, the opaque component. And so that compares those two different types of lesions. This shows a very early radiographic change where you just see a little bit of PDL space widening. I always talk of PDL space widening when I associate it with a periapical inflammatory lesion as a non-specific finding because it could represent what? It could represent a response to occlusal trauma or actual trauma to the tooth, or it could be an early indicator of periapical periodontitis, which in this case it is. We do see the large caries. So always look at the crown as well. If you see large caries invading the pulp space, you have all the more reason to believe that that could be a cause of periapical inflammation. All right, a few more examples here. This one shows how it's very well defined in most areas, maybe a little bit ill-defined here toward the mesial. This is a good example of showing how it communicates with the PDL space. The PDL space kind of widens around it. The same thing happens on this lesion right here. And so that's a good thing to look for, a good sign for periapical inflammation. If you suspect something's coming from the periapex of the tooth, it should first start to kind of widen the PDL space and emerge from there. So contrast that, you have your anatomy now, you know what a fossa looks like, you know what the lateral fossa looks like. If you see a radiolucency where you suspect a lateral fossa, and you don't see that PDL space kind of widening around and enveloping the periapical lesion, more likely that it's just the lateral fossa. But in this case, does it look like that or more of a periapical lesion? Yeah, we see the PDL space widen and kind of form this lesion going around the tooth that's clearly a periapical lesion. This shows more of a sclerotic lesion, so what do we call that? Condensing osteitis. Remember that term? And as I said, I'll typically always see some degree of radiolucency around the apices. It's never just strictly radiopaque. We'll get to dense bone islands, which are also called idiopathic osteosclerosis in a minute. Typically those have uniform, normal PDL space, whereas this one, it looks more like a little radiolucent outline around the roots of the tooth. And so this is a condensing osteitis. These arrows are just indicating how it's ill-defined. There's a gradual transition from the sclerotic part of the bone, where there's very dense trabeculation, to where the bone is more normal here in the alveolar crest. All right, more examples. Just your typical inflammatory lesions. A lot of these have very dense bone, very sclerotic bone around it, with, in this case, a pretty well-defined round border, but radiolucencies at the apex. This one looks pretty similar, maybe more of a blended, ill-defined border down here, surrounded by some sclerosis. This one as well, some areas well-defined, some you might describe as more ill-defined. All of these look pretty similar. This one has a very large sclerotic component, so I would look at this and call it condensing osteitis. But all of these, if you notice them, they have radiolucencies at the apices. As I've said, I've never seen a periapical lesion that's only purely radiopaque and has a uniform PDL space. That's what you're seeing here. If you just looked at this part of the lesion, you would think, okay, maybe this is a dense bone island, but it looks like it's arising from the clear periapical pathology, periapical inflammation from that molar. All right, I think I've repeated this enough, but just in case, what is the name for that one? It's mostly radiopaque, condensing osteitis. You can also call it sclerosing osteitis. That's a term the pathology book uses. So sclerosing or condensing osteitis. All right, we said abscess was a term for more acute inflammatory cells and purulence. So this is more of a clinical than a radiographic diagnosis. If you wanted to get your final diagnosis and know exactly what type of cells are in there, you would have to do histopathology to determine that it was acute cells in there. But if you see that there's pus arising from a lesion, if you have a sinus tract, usually that's because pus eats its way through the bone, and you can have a sinus tract, and that's more likely to be associated with a periapical abscess. And so, yeah, radiographically, we can't really distinguish between these two, but granuloma usually infers more of the chronic apical periodontitis. The chronic granuloma is what we're going to call it. So, yeah, not a radiographic diagnosis, more of clinical and the other signs and symptoms that are going to lead you to whether it's a granuloma or abscess. All right, so periapical cyst. We said this is when some epithelial cells, specifically the rest cells of Malassez, they react to inflammatory byproducts that are being released by this periapical inflammatory lesion. And they're stimulated and they undergo cystic degeneration and form an actual cyst, so an epithelial lined sac of fluid. And the fluid continues to accumulate, and it's that fluid accumulation that causes this cyst to continue to grow. And because it is from a periapical inflammatory lesion, it should be associated with a non-vital tooth. The cyst itself is going to be asymptomatic. Of course, it can have symptoms from infection, from inflammation going on at the same time from the tooth. But the cyst, if you look at this, you can imagine the part of the cyst in the palate, it's overtaking most of the palate here, would be more asymptomatic. Maybe they'd have symptoms still from the tooth, but in most cases, these are not symptomatic. So how do you distinguish when it might be a cyst? Or radiographically, when might I say it's a cyst as opposed to just a granuloma or an abscess? And once it gets to a certain size, there's no black and white cutoff, but abscesses, granulomas, they tend to be limited to a certain size. If an abscess grows, it usually forms that sinus tract, and then it relieves the pressure in itself. But a cyst continues to grow. So I would say if it's more than around a centimeter enlarged, if it has a very sharp corticated border, a very crisply defined corticated border, and it's very round in shape, all those things are signs that it might be a cyst. So a couple examples of those. Here's a large cyst. Where does it look like the center of the cyst is? If you're trying to guess which tooth it's from, both these teeth have some restorations with recurrent caries. Does it look like it's arising from right there? Does that look more like the epicenter of the lesion? Or does it look like this is maybe a little closer to the epicenter? I would say, yeah, probably this one. And so the lateral incisor tooth number 7 is likely the one, even though it doesn't look like it's large of recurrent caries, but the restoration goes all the way into here. If I were to guess, I would say that probably comes from tooth 7. You're going to do vitality testing. And the periapical cyst, even though it's taken on a life of its own, again, we said it arises from a necrotic tooth. So I would suspect that tooth 6 is necrotic in this case. Here's a periapical cyst. Partially has well-defined corticated borders, but then partially it has some ill-defined borders. And this is a cyst that's lost its well-defined cortex due to secondary infection. If anything communicates into the oral cavity, we know the oral cavity is filled with bacteria and it can get secondarily infected, and that can kind of eat away at the nice well-defined corticated borders. But you see enough of this that hopefully you can surmise that it's really arising from a well-defined lesion, something like a cyst, as opposed to a malignancy. A couple other examples. What does this look like? This kind of looks like a bag of fluid that's very cyst-like in appearance. Very well-defined, corticated borders. And so this looks like it's developing into a periapical cyst. I said, as a general rule of thumb, if it grows beyond a centimeter, start thinking periapical cyst. So what does that mean as far as treatment? How is the treatment for a cyst different than granuloma or abscess? If it is a true cyst, doing this root canal is not going to get rid of that cyst, and that has to be enucleated. So it's going to have to require surgery, either surgical endodontics. If the tooth is going to be excised anyway, then that cyst can be enucleated through the extraction site. This one, if you're not looking at 3D images, might be hard to tell. You can probably recognize that that's a tooth there. But what we're looking at is a coronal slice. A coronal slice is in this direction. So it's as if you're looking right at the patient. So if I'm looking at the patient, I'm just seeing one slice that's less than a millimeter thick. This to me looks like about 0.3 millimeters thick slice. And so you're just seeing one section of the tooth. What's up here? What's above the maxillary tooth? Maxillary sinus. And you're seeing this, what we would call radiolucent, but in 3D imaging we're just going to call it hypodense. We'll call it a dark area, very round, a cortical border around it. And so that looks very cyst-like, just like this one. And it looks like a cyst that's growing, it's expanding into the maxillary sinus. Over here more medially we have the nasal cavity. This is a nasal turbinate. And we're not going to get too much into cone beam interpretation or 3D interpretation in this course. But just to show you that all the radiographic signs are the same as what you're looking for in two-dimensional imaging. And fortunately, that's true of a lot of things for three-dimensional interpretation. Okay, these are the same patient, a panoramic and occlusal radiograph. This one really shows that kind of raised periosteal or cortical border around it. I call it periosteal because it's expanding beyond the bone. It's expanding beyond the normal cortex, which is obviously right here. But it's maintaining this kind of cortical border around it. And so that's the periosteum that's laying down that calcification. What does that tell you? If it's able to continue to lay down calcification as something is growing, it means it's slow growing. If it were growing too rapidly, you would not be able to form that periosteal calcification around it. And so the same is true whenever you see cortication around a lesion. If you see a corticated lesion that looks like a cyst, it means it's slow growing. It could be a benign tumor, but this just does a really good job of showing that thin buccal cortex, that hydraulic shape, very cyst-like. What is this? This is the one I call the eye of Sauron because it looks kind of like an eye, an iris. And so it looks a little bizarre, but if you look at the borders of the lesion, you have these nice, well-defined, rounded borders. And then what's going on in here? This is a previous lesion that was excised, or actually in this case they say it was just treated by endodontic treatment, and it started to heal on its own. And so bone healing comes from the periphery in, and it creates this almost iris shape, almost radiating pattern. You still have a bit of a radiolucency here. This could just be scar tissue. And so that's what a healing radicular lesion looks like. All right, yeah, it may be impossible to differentiate from when a cyst is small. I said 1 centimeter before, but really if it's above 2 centimeter, you really have to start thinking of a cyst, that well-defined corticated round border. I covered all of this. We'll talk about osseous dysplasia in a minute. And we'll talk about some of these other lesions later on. So you can use this slide to go back and compare once we've covered these other lesions. I don't want to get too much into detail right now. But clinically, what's the best way to differentiate a radicular cyst from other types of cysts? What did I say is specific of a radicular cyst? That's the only one that arises from a necrotic tooth. And so you should expect a necrotic tooth if you suspect a periapical cyst. You should expect a necrotic tooth if you suspect a periapical cyst. You can imagine, though, a situation where you've had a necrotic tooth and you had a periapical cyst, and then that tooth was extracted. And what happens to that cyst? If you don't extract the cyst, as I said, it carries on a life of its own and can continue to grow. And so that's what you call a residual cyst, just a periapical cyst where the tooth has been extracted. This looks like a large lesion. Just seeing that, you could think it's any of these other pathologies that we're going to cover. OKC comes to mind. But you compare with the patient's history, and they had a tooth there that was infected. They had a periapical lesion. That tooth was extracted. And this is just a cyst that's remained after extraction of that tooth. You can see it's deflecting the inferior alveolar canal inferiorly. Very corticated borders. Sometimes you lose that corticated border, but if you see any area where it's very well defined and corticated, you're going to have under differential more the well-defined, the benign type of thing, cysts or benign tumors. And again, we said the history is going to reveal a lot for you if you suspect a residual cyst versus OKC or any of these other things that may resemble a cyst or benign odontogenic tumor. Vitality test to confirm a necrotic pulp, always root canal therapy or extraction. If it's large, it's not going to go away. So if it's above more than 2 centimeters, it's going to require excision. Whenever you excise some suspected pathology from a patient, it should be biopsied. This is another 3D view. This is more of a sagittal. Before I had a coronal, this is sagittal, so as if you're looking from the side. You can hopefully appreciate the dentition here. And again, we see that corticated border around it. We're going to point out a different type of lesion that doesn't have a corticated border around it and talk about what that means. But when it has a corticated border around it, that means there's some type of lesion arising from within the bone, and that corticated border is growing with the lesion. It's being pushed into the maxillary sinus. Let's go quickly through this. Another example through the coronal plane. You do see a little bit of that corticated border. We also see some sinusitis. The sinuses should be nice and dark like this. They should be filled with air. But this is a periapical lesion that has led to odontogenic sinusitis. Same lesion, just from the axial, the horizontal view. So we're looking through the sinuses here. You can obviously see one sinus is different than the other, as one is opacified and the other is dark as it should be, hypodense. What else do we see? So this shows some periosteal bone formation, meaning that periosteum is going to react to inflammation. And in this case, it lays down a layer right here. And you can see kind of this double layer of bone. That's from this periapical inflammatory lesion. See the radiolucency right here? Similar thing going on here. We get a little bit of sclerosis, a little periosteal reaction. But this arrow indicates what? I told you to differentiate bone from soft tissue. You look for that cortical border around it. This has no cortical border. This is just more of a soft tissue thing. And this is what we would call mucositis. The mucous membrane in the sinus, the Schneiderian membrane, in health, it should be so thin that you can't distinguish it radiographically. And it's pretty common to get mucositis even without odontogenic inflammation like we see here. But if you see some mucositis that's localized to the area of an odontogenic inflammation, you can surmise that it's reactive to that it's probably an odontogenic mucositis. That's not as serious as sinusitis. That's not going to require a separate treatment. But if this odontogenic infection gets taken care of, then the odontogenic mucositis should subside. So here we see some mucositis even without any apparent periapical inflammation going on. These all have good, nice, uniform PDL spaces around the roots. The sinus is intact. Here's the zygomatic process of the maxilla. But all throughout the sinus, you have this mucosal thickening. I think of this as similar to gingivitis in that everybody has some degree of it. Not everybody, but most people have some degree of mucositis going on. It's not perfectly healthy, but it doesn't always require treatment. Yeah, in gingivitis, you probably are going to treat with at least a cleaning, a dental cleaning. But you'll see this a lot of times in patients. And just a typical small mucositis is not going to require a referral. All right, retention pseudocyst. Why do I say this here? Don't call these mucoceles. A lot of dentists will call these mucoceles. We want to stay consistent with ENTs. You know, they're kind of the specialist of the sinuses. Mucocele to an MD or an ENT is going to be very different. That's when the sinus gets completely filled with fluid. That's more of a sequelae of sinusitis. And it's a kind of a serious sequela of sinusitis, where the sinus gets completely obstructed and pressure builds up in the sinus, and the sinus starts to expand. That can expand into the nasal cavity usually, sometimes even up into the orbit. So it can be pretty serious, easy to be taken care of if treated early. But again, I'm just going through this all to point out to not call these mucoceles. This is a retention pseudocyst, and this is just a little localized area of obstruction of drainage within the mucosa of the sinus. Nothing serious, just an incidental finding. It's really rare that these are going to cause obstruction of the sinuses. So these are things that you can just kind of note in the patient's record. But how would we distinguish these from those lesions I was just showing you that expand into the sinus and can appear similar? What's the difference between when something's just a soft tissue or a fluid-filled entity versus bone growing into it? A lesion that's a periapical lesion, or one of these other type of lesions that we'll get to later on in the course, an OKC, a meloblastoma, anything that arises from the bone, if it expands into the sinus and it's one of these slow-growing tumors, it'll have a cortex raise around it. I've never seen an example where one of those didn't. And so this has no cortex around it. It's all just more of a soft tissue, fluid-filled Schneiderian membrane. As I said, very common. These will come and go on their own, don't require treatment, and you will see these. So know that name. Mucus retention pseudocyst, or I just call them antral pseudocyst. This is what I just went over, hopefully ad nauseum at this point. Sinus floor is going to be displaced if it's an odontogenic lesion arising from bone. Malignant neoplasm, we'll get to a little bit later on. This just, your typical malignancy is just going to destroy bone. So it doesn't really have that cortex around it that raises the sinus. Typically, malignancies aren't going to have a cortex. If I see a cortex, I'm thinking more of one of these, cyst or benign neoplasm, whereas malignancy just destroys bone. It can grow into the sinus, and then you'll see the soft tissue of the tumor. Usually not this nice rounded dome-shaped thing that you see with a pseudocyst. Maybe a little bit more irregular soft tissue appearance. But management for pseudocysts now is just make note of it. If they do get sinus symptoms, maybe they'll have to be checked out later, but in most cases, it's not going to require any treatment. All right, what do we see going on here? Look for your sinus borders. Look for all your anatomical structures again. Sinus borders intact. This one looks almost a little sclerotic, but if you compare with the entire pterygomaxillary fissure, it looks a little bit blurred. And what do we see going on here? Very large dome-shaped radiopacity. Does that have a corticated border around it, or do I suspect just a soft tissue thing? And this is no cortex around it. In fact, the sinus borders remain intact down here. This is just a pseudocyst. Over on this side, the sinus border kind of overlaps with the hard palate line, so you can't really see it, but it is there and it's continuous. Well, the point I was making over here, this entire area is blurry, so I think there's some degree of rotation. Teeth aren't perfectly symmetric, creating some of the blurring over here. It could be related to some degree of chronic sinusitis, but I don't strongly suspect that. So that was just showing a pseudocyst. This one looks Very similar, it just happens to be a lot more clear, as all these structures over here are a lot more clear and within the focal trough. But look at the sinus border, completely intact, nothing raised around it, nothing going around the apices of these teeth. It looks like a periapical lesion. This is just another pseudocyst. I've got plenty of examples of these. They all start looking the same when you've seen enough, so I'm giving you plenty of examples. What's this right here? Little bird-shaped line. This was taken probably around 2020 or 2021 when everybody was wearing masks, right? They had their mask down. And so this is just the thin wire from a mask that the patient was wearing. Another example over here. This looks like it could have a periapical lesion around it. But the way this is so dome-shaped, I still suspect just an antral pseudocyst. If it were some mucositis, odontogenic mucositis, it would more be localized to the area of inflammation right here. Idiopathic osteosclerosis, a lot of synonyms to this. I might just call it a dense bone island or anostosis. So this is a very common thing. You'll see in quite a large percentage of your typical patient is going to have just anostoses, dense bone islands. Well defined, sometimes irregular in shape, as it kind of fills in the marrow space with compact bone. Called idiopathic because we are not really sure why this happens. It happens all over the body, not just in the oral cavity, but you'll see these a lot in the oral cavity. I have it in this lecture because you see it around the roots of teeth and you start thinking, okay, I need to distinguish this from a condensing osteitis. There's an example down here in the anterior mandible, I guess right below the premolar. Here's what I was talking about with a periapical lesion. You never see where the PDL space is completely uniform like this. And so I don't see really much evidence at all that there's a periapical inflammatory lesion. So this one I'm not really suspecting is a condensing osteitis. You look at the tooth, there's no caries, no obvious fracture. If there's no symptoms, you do want to vitality test a tooth like this and rule out condensing osteitis. But just on that appearance, I strongly suspect it's just a dense bone island, just idiopathic osteosclerosis. Here we have some 3D images. Let's just jump down here. Here we have some idiopathic osteosclerosis. We also have some root resorption, which I haven't got to yet. But you can have some root resorption. I still don't see a lot of evidence of periapical inflammation here. Nice uniform PDL space. Pretty much uniform PDL space. Maybe you're losing that a little bit with the external resorption. And here's a fairly large lesion. Well defined. Occupies a lot of the body of the mandible here. All right, does this look like condensing osteitis or idiopathic osteosclerosis? And how do you tell? You look for some degree of inflammation of radiolucency at the apex of the tooth. And either of these teeth, it looks like nice uniform PDL spaces. Just another example of the dense bone island. This one, the positioning is what really stands out to me. What did we say about that from your panel lecture? Narrow teeth anteriorly, were they too far forward or too far back? I guess the amount of spine that shows in this case may be a hint as well. They were way too far forward. You get forward of the focal trough, and those teeth narrow. They get minimized, they get kind of shrunk down because the only thing in proportion is what's in the focal trough. But the reason we have this in here is for this lesion right there, just another well-defined, although it doesn't look perfectly uniform, there's some variation to idiopathic osteosclerosis and it can look like that. All right, so you do want to distinguish from condensing or sclerosing osteitis. So vitality test the tooth. If it's vital and they're asymptomatic and you don't see any inflammation coming from the root of the tooth, more likely it's just idiopathic osteosclerosis. We'll get to osseous dysplasia next, and we'll cover these other things a little later as well. No management for idiopathic osteosclerosis. We'll talk later on if you do have several very distinct, I would say more than 5 very distinct lesions of idiopathic osteosclerosis, you might want to start thinking of familial adenomatous polyposis, which is which is related to Gardner's disease. We'll talk more about that later in the course. So cemento-osseous dysplasia, focal areas of altered bone metabolism. So instead of normal bone metabolism, where you retain the normal trabeculae and marrow spaces, this is a disease where you're getting fibrous tissue, just fibrous connective tissue that over time it starts to calcify. When these lesions are early, it just resorbs the bone and it's being replaced by this connective tissue, and it looks radiolucent. So it can look exactly like a periapical inflammatory lesion. These are the different types of terms just based on the location. It's most commonly limited to the anterior mandible, and we'll call that periapical cemento-osseous dysplasia. If it's limited to a single site but outside of the anterior mandible, which the most common place for that is going to be the posterior mandible, we'll call that focal cemento-osseous dysplasia. If it's in more than one sextant, then we're going to use the term florid cemento-osseous dysplasia. And you may see this just all over the jaws. We'll show you some examples there. So periapical, as I said, this is the most common. So in the anterior mandible, this one is more common in blacks than Asians, more so than whites. But these lesions, the reason they're in this lecture is they're so common. So I wouldn't rule out a lesion just based on demographics one way or the other. Not associated with pain or symptoms, not associated with a non-vital tooth, right? So you want to vitality test these teeth and rule out that it might be a periapical inflammatory lesion. Look at these teeth though. I see nothing going on in the crowns of the teeth, no reason to suspect pulpal necrosis. So when I see that, especially in the anterior mandible, I want to first of all think, could this be cemento-osseous dysplasia? As I said, early on they look just like this. They look completely radiolucent, indistinguishable from a periapical inflammatory lesion, but clinically you can distinguish it. So clinically, how are you going to distinguish it? Hopefully you picked up on that. Do the vitality test. An inflammatory lesion will come from a non-vital tooth. Cemento-osseous dysplasia is going to arise at the apices of vital teeth. And as they mature, you start to see this go on. You get this cloudy opacification, cloudy calcification. These are pretty dense. It may start as just very sparse granular calcification, and it comes from within the center of the lesion. If you can remember, think back to how some of those periapical inflammatory lesions look that were mixed, because you can have a mixed appearance to an inflammatory lesion, but for those you get radiolucencies of the apices, and then that's surrounded by opacity. Here, yeah, we see radiolucency around the apices, but the radiolucency continues all the way around this lesion. That would be very atypical for a periapical inflammatory lesion, even one that has some condensing osteitis with it. Sometimes if you look close at the PDL space, the calcification kind of outlines a normal PDL space, and that's a sign of cemento-osseous dysplasia rather than a periapical inflammatory lesion. So a lot of little subtle things that you can pick up on as you look at more and more of these lesions, as you get more experience. But radiographically, it can tell you a lot, even though we always say radiographically we're not making a diagnosis, we're just coming up with a differential. There are a lot of little subtle signs that can lead you to what the lesion is. This one I would classify as even more mature than the last one, where it's calcified almost all the way through, but you still see a little hint of radiolucency around the calcification. Look at the PDL space here, nice and intact and uniform, same with the canine there. And so that's kind of distinguishing it from a periapical inflammatory lesion, but why would I say this is not idiopathic osteosclerosis? And it's that loosened outline that I pointed out before. So it maintains that lucency around it. These are kind of mixed, kind of have a lucency around it, varying thickness, but no real lucency right at the apex like you would expect from an inflammatory lesion. These also appear somewhat granular, which is going to be common for osseous dysplasia. And the book talks about them as often being surrounded by sclerotic bone. Here we see a sclerotic border around it. In this case, you don't necessarily see that, so sometimes you see that sclerotic border around these lesions. This is an interesting one. These are panoramic radiographs that were taken 3 years apart, and they developed a cemento-osseous dysplasia lesion that calcified within those 3 years and has this lucency around it. Now looking at this, I might think infection, I might think osteomyelitis. We haven't got there yet, so I'm kind of getting ahead of myself here. We'll talk more about what a osteomyelitis sequestrum is though. Here we see more of that granular, cloudy appearance, mixed lesion, but the lucency does what? It goes all the way around that calcification around it. I don't see lucency just localized to the apices of the tooth, which I would expect to see with an inflammatory lesion. This one again, lucency around the outside of it, kind of a cloudy, amorphous, calcific mass internally, very typical of cemento-osseous dysplasia. So what did I say we call these ones that are localized to one area outside of the anterior mandible? This is a focal lesion. All of these are focal cemento-osseous dysplasia. Then this just compares different lesions and how they may look differently. Sometimes these will be associated with large radiolucent components, and they found that these are associated with simple bone cysts, which is another thing we'll talk about later in the course. But all these have that kind of cloudy calcific mass, radiolucency around the calcification. It starts to calcify in the center, near the apices of the teeth, and all of those are very typical of cemento-osseous dysplasia. And what do we call it when it's more than one sextant? So we said periapical for the mandibular anterior, focal if it's just one point outside of the anterior mandible, but multiple sextants, you're going to call it florid or widespread form of periapical osseous dysplasia. It can be pretty extensive. It seems like these florid ones are more likely to expand compared to the other types. Frequently it affects both jaws, but it's more common in the mandible. Another example, this looks mostly radiolucent, right? It almost looks like it's scalloping between the teeth. We said that these lesions can be associated with simple bone cysts, and that's something that a simple bone cyst is known to do, that scalloping pattern in between the roots of teeth. But we also see some radiopaque component. And so this is somewhat a mixed lesion, very sclerotic border down here. That would not be typical of a simple bone cyst. And so this mixed component is what may give away that it's a florid cemento-osseous dysplasia. If you look at other areas as well, something going on here, do they just happen to have a periapical lesion? Or is this more florid cemento-osseous dysplasia? Some more dense area here and lucent around that tooth. And so that's another example of florid. Here's one in an older patient. You see cloudy appearance like this to the jaws. The first thing that may come to mind is Paget's disease, but it's really isolated to the periapical region of the teeth. And this is just very mature florid cemento-osseous dysplasia. So this is one that's a radiographic diagnosis. This is one where you want to avoid biopsying if you can, because these can lead to infection. They are more prone to infection. So if they're asymptomatic and you don't test that a tooth is necrotic, if all the teeth are vital, treatment is typically not advised. You want to monitor these. You want to put down that you suspect that it's cemento-osseous dysplasia, and just monitor, just because of the risk of other complications if you do cut into these. There may be some rare circumstances if one of these is extremely expansile, if it's causing other functional or aesthetic issues where some shaving may need to be done. So similar treatment as fibrous dysplasia. But in most cases, avoid treatment. Just continue to monitor these. All right, getting on to hypercementosis. What is hypercementosis? You can think of this as just an excessive deposition of cementum. It's kind of like a benign tumor, although not an official benign tumor of cementum. In fact, that's what we'll cover next. But this is just some idiopathic growth of cementum that kind of widens the root of a tooth. There are certain things it's associated with, which we don't really need to get into. But really the takeaway from this is it might affect the difficulty of extraction. It kind of widens, it creates a bulbous root apex. And so if you're trying to extract a tooth, obviously it's a lot easier to extract a conical root than it is something that has a ball at the end, so a bulbous root. This is a pretty extreme example right here of this molar. So how do I know, or how can I distinguish this from idiopathic osteosclerosis? I would have a more normal looking root in idiopathic osteosclerosis. And where would the PDL space be? It would follow the outline of the root. In this case, the PDL space follows the outline of the hypercementosis. And notice that the PDL space is uniform in thickness. It's not widened. That will contrast it with all these other lesions we're talking about today. This is kind of your more typical appearance of hypercementosis. You see it a lot of times on the premolars, where the root just looks widened throughout the apical segment. PDL space, again, nice and uniform, nice intact lamina dura around it. Same with that premolar. And another example now of mandibular premolars. The cementum is just kind of widened around the tooth. For this one, the cementum tends to look a little bit more radiolucent, but look at the PDL space. And it's very uniform going around these lesions. So that's hypercementosis. So how do you distinguish hypercementosis from those that originate outside of the root? Look at what? Look at that PDL space. If it's uniform and going around the lesion, you don't see any part that looks like a wider radiolucent capsule around it, which is going to lead us to our next thing, cementoblastoma. That uniform PDL space around the outside of it is a strong indicator of hypercementosis. All right, so this one is a true neoplasm, a benign tumor of cementum. These may be difficult to distinguish from hypercementosis. What I find with these is they tend to be very spherical in shape, very round. Look at the radiolucency around it. Is that nice and thin and uniform like we saw with hypercementosis? Or are parts of it a little bit wider? And yeah, parts of it are a little bit wider. Another thing that may help distinguish these is they tend to be symptomatic. They tend to cause pain. So if a patient gets severe pain from a tooth and there's no real known cause of that pain, it doesn't look carious, the tooth tests vital, but you see a lesion like this, that's another indicator of the fact that it might be a cementoblastoma. And this pain is known to be relieved by anti-inflammatory drugs. And so they may say, yeah, I take ibuprofen and it goes away. Another indicator of cementoblastoma. Most of these, almost always, not exclusively, but most of these are going to be on the roots of first mandibular molar, or sometimes premolar. Just think one of the posterior mandibular teeth. Well-defined, corticated. I said this really stands out to me, that's why I highlighted it yellow. Almost perfectly round in a lot of these cases. Mixed structure, it's going to be mostly radiopaque. We kind of think of this as one of our radiopaque lesions, but remember it has that radiolucent rim around it. So this is one I'll bring up when I say target lesion, meaning it looks opaque but has a radiolucent rim around it. We're just covering it in this lecture because it is so common. But sometimes it will have an amorphous pattern. It can look a lot like cemento-osseous dysplasia, like we talked about, with kind of that granular internal appearance. Or it is known to have a spoke wheel pattern, where it looks like radiating, striating lines from the center. And so that's a common appearance of cementoblastoma. Effect on other structures, remember, this is always something you include in your description. A lot of times this will resorb the root of the tooth that it's associated with. So that's an indicator of possible cementoblastoma. Here are several examples. What's similar between all of these? They're all nice and round, almost softball shaped. Varying thickness of that radiolucent capsule around it. That's an indicator that it has a soft tissue capsule around it that you see in cementoblastoma. They're resorbing the roots of the teeth. These have more kind of an amorphous granular pattern. This one might have a little bit of radiating, but this one does have that spoke wheel radiating pattern that they described. Here in the 3D slices, just a tangential slice to the jaw here. We see it has more of a granular pattern. That soft tissue capsule has expanded and resorbed the lingual and buccal cortices, so it can expand through the cortices of bone. Cemento-osseous dysplasia, typically asymptomatic. We said that can help distinguish a cementoblastoma. And remember that radiolucent band around it, although that can look really similar in periapical cemento-osseous dysplasia. Sclerosing osteitis, that won't have that radiolucency around the outside of it. Also not as round. Most things aren't as nice and round as a cementoblastoma. Dense bone island is not going to have any degree of soft tissue capsule, any degree of radiolucency around it. Hypercementosis, what did we say about that? Look at that PDL space to remain uniform and intact around it. All right, these are self-limiting, but they can be painful. So probably if you see a cementoblastoma, it's going to need to be excised and biopsied, verify your differential diagnosis. Okay, so root resorption, which is really common. You see mostly on the external of teeth, but we'll talk about the difference between external and internal. So this is caused by resorption of tooth structure by odontoclasts. So these cells are resorbing the outside of the tooth or inside of the tooth. For internal resorption, it comes from the pulp chamber and from the root canal walls. So what we expect to see with internal resorption, you see it looks like the root canal has widened in that area. External resorption, just like it sounds, that resorption comes from the outside. Usually the PDL space remains intact. There may be different causes, inflammatory lesions, tumor cysts, these things can resorb roots. That's one of those effect on other structures. When you see some separate lesion, if it grows into the root of a tooth and resorbs it, you always want to describe that. But a lot of times it'll happen for unknown causes. Common to occur the apices. What's seeming more and more common is to see this cervical resorption, this invasive cervical resorption, they call it. And yeah, the bone, the PDL space, they kind of grow in as that tooth is resorbing. And we'll show that with these examples. Here the apices just look shortened. The PDL space is intact, look kind of rounded. And same thing for these mandibular teeth. In this case, the molars in this patient, they just look shortened. They just look like short roots. And so the PDL space remains intact. And you can say that's likely external resorption. So here are a couple other examples. I like this one because you can see the bone growing in from the distal surface of the root of this tooth. PDL space still remaining intact. In this case, you see radiolucency on the outside. And so this is buccal or lingual resorption. It's still external resorption. I can tell that because the canal spaces remain intact going right through where you see this radiolucency. And so this is either buccal or lingual external resorption. This shows a 3D view. Now we're looking at that tooth from the side. So you're looking at more of a sagittal plane, a cross-sectional image of what looks like a maxillary incisor. And you can see from the palate this resorption and the PDL space remaining intact. And this looks like normal bone. So the bone just kind of invades from there. As opposed to internal resorption, we said that comes from the pulp or the root canal of a tooth. Certain things can cause it. Sometimes it's unknown cause, just like with external resorption. And it'll look like enlargement of that pulp chamber or the canal space. So in these ones, where do we see internal resorption or something else? And I think of this as a snake. It looks like a snake that swallowed a rat, right? And where that pulp space or the canal space widens around where the resorption is. And so that's a clear sign of internal resorption. Same with this one. The canal space communicates with this resorption lesion and widens around it. What's different about this one? So this is a good comparison. Is this internal resorption where the canal space just widens around it, or you still see the canal, the pulp space, going through the lesion? And so this just looks like a radiolucent, probably a facial composite on that lateral incisor. There's a pretty extreme example of internal resorption coming from the pulp space, really resorbed through the trunk of that tooth. All right, thanks for watching. We'll see you next time.